Hey everyone, welcome to MediByte. I'm absolutely thrilled to be your host for today's explainer, where we're going to unpack a medical condition that honestly causes immense physical and emotional stress. But here's the good news, it's incredibly treatable. We're talking about genito-pelvic pain and penetration disorder. You know, as healthcare professionals here at MediByte, we see how issues surrounding sexual health and pelvic pain are just shrouded in so much silence and stigma. Well, today, we're stripping all that stigma away and replacing it with clear, authoritative medical science. If you or someone you love is experiencing severe pain during intimacy or even just basic gynecological care, you are exactly in the right place. Let's get into it.
Why does it hurt so much? And is it all in my head? Wow, this is a question doctors hear all too often. Let me just validate your experience right now. Right out of the gate, your pain is entirely real. It's deeply understood by medical science, and most importantly, it is completely involuntary. You're not making this up, you aren't overreacting, and you are definitely not broken. This pain is the result of a really complex web of physiological and neurological responses, and we're going to break all of that down together today.
So, here's the clinical pathway we'll be following for this explainer. First, understanding the condition. Second, where it hurts. Third, triggers and causes. Fourth, diagnosis and clinical evaluation. Fifth, treatments and therapy options. And finally, taking back your health.
Okay, let's dive into this. Part 1. Understanding the condition. Demystifying the diagnosis. To ground all of this in objective medical science and permanently remove any lingering shame, let's start with the actual diagnosis. Genito-pelvic pain/penetration disorder encompasses pain during sexual intercourse or any sexual activity involving penetration paired with an involuntary contraction of the muscles right around the opening of the vagina. Historically, you might have heard this called vaginismus or levator-ani syndrome. In practical terms, this means the disorder makes intercourse, using a tampon, or even a routine pelvic exam painfully difficult. But the absolute key word here is involuntary. This is an automatic muscle reflex. It's kind of like blinking when something flies at your eye. It's not a conscious choice you're making to tense up.
Moving right along to part 2, where does it hurt? Categorizing the pain.
To properly treat pelvic pain, we first have to map it. Identifying exactly where it hurts empowers you to better pinpoint and communicate your symptoms to your doctor. Essentially, this pain can manifest geographically in 3 distinct areas. First up is vulvar pain, specifically provoked vestibulodynia. This is pain on the external genitals that happens when the vulva is touched, sometimes even with incredibly light pressure. Next is vaginal pain, or dyspareunia, which happens right as something is inserted. And third is deep abdominal pain, or deep dyspareunia, felt deep in the belly during or after insertion. Patients often describe these sensations as burning, sharp, or cramping. And because those pelvic muscles tend to become so tight in response to this, the pain is unfortunately amplified.
Now, what's really interesting about this next part is the mind-body connection. Section 3, triggers and underlying causes.
So now that we know what it is and where it hurts, we need to figure out why it happens. Looking at the triggers, it's really this complex web of physical and psychological causes. On the physical side, the pain might be kicked off by the genitourinary syndrome of menopause, where a drop in estrogen leaves tissues thin and dry. It could also stem from vaginal infections, endometriosis, or even an allergic reaction to something like contraceptive foams. On the psychological and reflexive side, things like a deep fear of pain, chronic stress, or a history of trauma play a massive role. What usually happens is this: a physical trigger causes an initially painful experience, and then the psychological anticipation of that pain happening again triggers your body's defense systems for any future encounters.
In that anticipation, it often develops into a condition called levator-ani syndrome. The levator-ani is your main pelvic floor muscle. With this syndrome, that muscle involuntarily contracts. It's typically triggered by a fear that penetration is going to be painful. So if you fear it'll hurt, your brain sends this rapid-fire signal and your pelvic muscles automatically tighten like a clenched fist to guard you. Again, I literally cannot emphasize this enough. This tightening is an automatic, involuntary response to protect your body. You are not to blame for this reflex.
Let's move to Section 4, diagnosis and clinical evaluation. Removing the fear.
Look, at MediByte, we fully acknowledge the intense, incredibly valid fear many patients have of painful pelvic exams. It's totally understandable. To demystify that process, let's look at how doctors actually evaluate and diagnose this. They use rigorous criteria from the DSM-5. They're looking for significant pain during penetration attempts, an intense fear or anxiety about that pain, and that involuntary tensing of the pelvic muscles we just talked about. Plus, these symptoms must have been present for at least 6 months and cause real distress. This proves to you that this is a formally defined, heavily researched, and deeply recognized medical disorder.
So the crucial point here is that you have a voice in your medical care, and there are concrete steps you can take to make the clinical evaluation highly tolerable. First off, discuss the exam with your doctor beforehand and set up communication rules, like picking a safe word to stop everything immediately. Second, ask to hold a mirror. This way you can see exactly what the doctor sees and really understand your own anatomy. Third, you can actually place your hand right over the doctor's hand to maintain a physical sense of control during the exam. The doctor might just gently use a cotton swab to touch different areas and pinpoint the pain. Taking these steps removes the fear and puts you firmly in the driver's seat of your diagnosis.
Part 5. Treatments and therapy options. Pathways to relief.
Transitioning into treatment brings a message of profound hope, guys. Healing from this requires a multidisciplinary approach. There's no single magic pill here. Instead, we tackle the disorder from all angles. On a baseline level, using high-quality water or silicone-based lubricants is absolutely essential. From a physical standpoint, pelvic floor physical therapy is a total game changer. Therapists use techniques like myofascial release and biofeedback to actually teach you how to consciously relax those tight muscles. Psychologically, therapies like mindfulness-based cognitive behavioral therapy are amazing for managing the fear surviving penetration. And medically, doctors might prescribe vaginal estrogen, gabapentin creams to soothe nerve pain, or even targeted Botox injections to relax the pelvic floor in more severe cases.
And this brilliantly illustrates one of the most effective physical therapy techniques, progressive desensitization therapy. This is all about safely retraining your nervous system to just turn off that involuntary tightening reflex. It starts super simply with daily self-touch near the vaginal opening to help drop that anxiety. Next, you might practice gently inserting one finger while actively bearing down, like pushing outward to relax the opening. Then, patients move on to using medical-grade, graduated dilators, leaving them in for about 10 to 15 minutes to let the muscles adapt to the pressure without contracting. Eventually, a partner is brought into the process once you're completely comfortable. It's a really empowering step-by-step journey of reclaiming your physical responses.
Finally, Section 6, Taking Back Your Health, Empowerment and Intimacy. While the physical therapies are obviously vital, true healing is also about maintaining closeness with your partner without this dark cloud of stress hanging over your head. It's highly recommended that you and your partner develop satisfying sexual activities that explicitly do not involve penetration. Seriously, take it off the table for a bit. Expanding your definition of intimacy removes that immense pressure that causes the muscle tension in the first place. By focusing on mutual pleasure through other ways, you break the cycle of anxiety and pain, which actually lets your entire nervous system take a deep breath and relax. It reinforces that physical closeness is safe, it's fun, and it's entirely under your control.
I really want to leave you with this final empowering thought. You are not broken. Taking control of your sexual health is the very first step toward reclaiming your comfort and intimacy. This condition is just a physiological response, and as we've seen today, medical science has incredibly clear, actionable ways to retrain that response and get you relief. So my question to you is, what step will you take today to advocate for your health and reclaim your comfort? Thank you so much for hanging out with us for this explainer. If you found this information valuable and empowering, please hit that like button, share this with someone who really needs to hear this message, and don't forget to subscribe to the MediByte channel for more deep dives into taking control of your health. Stay informed, stay empowered, and we will see you next time.